$194 billion in medical debt is currently in active collection in the United States. 94 billion in collections right now. According to a nationally representative study published in Health Affairs in 2025 using 2024 data. And the most important thing to understand about that number is not how large it is. It's how avoidable a significant portion of it was. There are two prices on virtually every medical bill in America. The chargemaster price, the sticker, which is what hospitals quote to uninsured patients and what appears on the bill you receive. And the negotiated price, which is what insurance companies, Medicaid, and informed patients who know their rights actually pay. The gap between those two numbers can be 50%, 60%, 70% lower than the sticker. Most patients pay the sticker. Not because they have to. Because no one told them the second price exists. Today we're covering what you can actually do when a medical bill arrives that you can't pay the specific steps in the right order. What your rights are as of 2026 and where the real options are. Not theory. The actual moves. Why the bill you received is not the final price. Hospitals operate on a pricing structure most patients never see. The chargemaster is the official price list, a document with prices for every procedure, test, and supply, set intentionally high. Insurance companies negotiate discounts off the chargemaster as part of their contracts. Medicare and Medicaid pay fixed rates set by the government. Both are dramatically lower than the chargemaster. Here's what most patients don't know. Uninsured or underinsured patients, the people who receive the largest bills, are almost never legally required to pay the chargemaster rate. They can ask for the negotiated rate. They can apply for financial assistance. They can negotiate a reduced settlement. The medical billing system was not designed to make these options visible. That is a design choice, not an oversight. The instinct when a large medical bill arrives is to treat it like any other bill owed in full, due on the date listed. That instinct is expensive. Step 1. Stop. Don't pay anything yet. Before you pay a single dollar, 3 things need to happen. Request the itemized bill. Every hospital is required to provide an itemized bill upon request, a line-by-line breakdown of every charge, every code, every supply. The summary bill you received is not that. It's a total. Request the itemized version in writing, email, or certified mail. You want a record of the request. Why this matters? Incorrect medical bills are extraordinarily common. A January 2025 report from ACASA estimated that incorrect medical bills cost Americans $88 billion annually. The percentage of bills containing at least one error varies widely by study. I've seen figures ranging from 40% to 80%, depending on methodology and what counts as an error, so I'll be honest that there's no clean number I can give you. What the research consistently agrees on, billing errors are common enough that you should always review the itemized breakdown before paying. Compare the itemized bill to your explanation of benefits. If you have insurance, your insurer sends you an explanation of benefits in EOB after any covered service. It shows what the provider billed, what the insurer paid, and what you owe. The itemized bill from the hospital and the EOB should match on key line items. Disparities between the two documents are disputes. You don't owe money for errors, for duplicate charges, for services not rendered, or for amounts your insurer should have covered. Dispute errors in writing with both the provider and your insurer. Do not pay disputed amounts while a dispute is open. Quick question before we get into the negotiation moves. Have you ever tried to negotiate a medical bill? Just drop yes or no in the comments. I want to see what percentage of people watching have actually tried it. There's one thing that most hospitals with nonprofit status are legally required to offer qualifying patients. It can reduce or eliminate a balance entirely. Almost nobody knows to ask for it, and the hospitals are not required to tell you it exists. I'll show you exactly what it is and how to access it in about 3 minutes. I need to stop here and correct something that was true when most of the medical debt content online was written but isn't fully true anymore. In 2024, the Consumer Financial Protection Bureau proposed a sweeping rule that would have prohibited all medical debt from appearing on credit reports. affecting an estimated $49 billion in outstanding medical collections. That rule was vacated by a federal court in July 2025. The current administration declined to defend it in court. As of April 2026, that rule is not enforceable. But here's what didn't disappear. The voluntary changes made by Equifax, Experian, and TransUnion in 2022 and 2023 are still in effect as of June 2026. These are industry decisions, not regulatory ones, and they currently protect millions of borrowers. Medical collections under $500, no longer reported to credit bureaus. Paid medical collections, removed from credit reports regardless of original amount. Medical debt under 1 year old. Not reportable, giving patients time to resolve disputes before a bill can damage their credit. The regulatory protection failed. The voluntary protections held. That's the current landscape. Any video on this topic that doesn't mention the 2025 court ruling is working from outdated information. Now the moves that actually reduce what you owe. The hospital assistance program I mentioned. And what to do if the bill is already in collections. The negotiation steps that work. Step 2, apply for charity care or the hospital's financial assistance program. This is the thing hospitals don't tell you about. Every nonprofit hospital in the United States, and roughly 58% of hospitals are nonprofit, is required by the heirs to offer a charity care or financial assistance program as a condition of their tax-exempt status. These programs can reduce bills by 50% to 100% for qualifying patients. Income thresholds vary by hospital. Many programs cover patients earning up to 200%, 300%, or even 400% of the federal poverty level. In 2026, 400% of the federal poverty level for a family of 4 is approximately $124,800. A middle-class household earning $75,000 a year can qualify for substantial financial assistance at many nonprofit hospitals. But the hospital's billing department is not going to mention this program when they hand you the bill. How to access it? Ask the hospital's billing department directly for their financial assistance application. It is a publicly available document. Submit it with proof of income. This is the single highest leverage move available before any negotiation begins. Step 3. Negotiate a prompt pay discount or hardship reduction. If you don't qualify for financial assistance or the balance after assistance is still significant, negotiate directly. Hospitals lose money when bills go to collections. A collections account returns roughly 20 to 30 cents on the dollar for the hospital. That means any offer above that rate is mathematically better for the hospital than sending the bill to a collector. Ask specifically, "I'd like to pay this balance in full today. What is the prompt pay discount available for a lump sum payment? I'm experiencing financial hardship. Can we discuss a hardship reduction on this balance before we discuss payment plans?" Hospitals don't advertise these discounts, but they exist at most facilities. Prompt pay reductions of 20% to 40% are common for patients who ask. Step 4. Set up a 0% interest payment plan before touching your credit cards. Hospitals do not charge interest on payment plans. That is not a minor detail, it is one of the most important facts about medical debt. A $6,000 medical balance on a hospital payment plan costs $6,000 to repay regardless of how long it takes. The same $6,000 on a credit card at 22% APR, paid over 3 years, costs approximately $8,400. If a balance remains after financial assistance and any negotiated discount, set up a hospital payment plan first. Then evaluate whether a low-interest personal loan or other financing makes more sense. Credit cards are almost always the worst financing option for medical debt. Step 5. If the bill is already in collections, you have options. A debt going to collections does not mean the debt becomes permanent or legally unchallenged. Send a debt validation letter within 30 days of the collector's first contact. In writing, the collector must provide verification of the debt before resuming collection efforts. If they can't verify it, collection activity must stop. You can also negotiate directly with the collection agency. Collectors typically purchase the debt for 10 to 20 cents on the dollar. Any settlement above that is profit for them. Negotiated settlements of 40 to 60 cents on the original dollar are common. Here is what I can't give you a clean answer on. The percentage of medical bills that contain at least one billable error varies by study from as low as 40% to as high as 80%, depending on how errors are defined and what kind of bills are examined. I've cited the $88 billion annual cost figure from ACASA. That's a credible source, but the precise error rate on any individual bill is not something I can quantify for your situation. What the range tells you: the probability of at least one error is high enough that reviewing the itemized bill is always worth doing. That's the actionable conclusion regardless of the exact percentage. Here is the number I held back. An estimated $44 billion in retirement savings is withdrawn annually to cover healthcare costs not covered by insurance, according to Fair Visit Health's analysis of healthcare financial data. $44 billion per year coming out of retirement accounts with a 10% early withdrawal penalty and ordinary income tax on top to pay medical bills that, in many cases, were negotiable or partially coverable by the hospital's own assistance program. This is not a small-scale problem. It is the second-order consequence of not knowing what we covered in this video: the existence of assistance programs, the negotiability of the sticker price, the availability of 0% payment plans. The retirement account withdrawal is what happens when the only option a patient sees is the sticker price on the bill. You did not sign a contract agreeing to pay the chargemaster price before your treatment began. You did not shop around for the best price on an emergency. You did not choose to get sick or injured at the worst financial moment. The medical billing system does not explain any of this to you. It hands you the highest number and waits to see if you pay it. You are not obligated to pay the first number on a medical bill. You are entitled to an itemized breakdown. You are entitled to apply for financial assistance. You are entitled to negotiate. And you are entitled to set up a payment plan at 0% interest before you ever put a dollar of medical debt on a credit card. None of this requires a lawyer. It requires knowing the system well enough to ask the right questions. Have you ever successfully negotiated a medical bill or accessed financial assistance from a hospital? Drop what happened in the comments, specifically what you asked for and what you got. I want to build a real picture of what's actually working for people. If this is your kind of channel, subscribe. See you in the next video.